So in this quick revision program, we'll start with the neurophysiology, starting with the properties of receptor. So in the sensory physiology, everything starts from the receptor. Then we will discuss about the afferent, then ascending pathway, then thalamus is the relay station, and cortex is like a television where everything is perceived. Suppose someone is touching you, you are perceiving at the cortex. You are seeing me, you are perceiving me at the cortex. So starting with the receptor. Number one, cutaneous receptor. So what are the properties of cutaneous receptor, doctor? Mnemonic is M-lid. M is modality, L is location, I is intensity, and D is duration. First of all, receptor has a modality. It can be for pain, touch, temperature, vibration. So it is called as a modality. Second is location. It is important for the receptive field size, area of skin from where receptor will collect information. It is called as receptor density. And receptor density is the basis for 2-point discrimination. See, smaller is the size, better is the 2-point discrimination. Okay, suppose that if I put 2 points like that and you are saying there are 2 points, 2 points, no 1 point. Okay, so this is the area, you are saying 1 point. So smaller is the size, better will be the 2-point discrimination, and it depends on the receptor density. So better is the density, better will be the 2-point discrimination. So this is shortest at the lips and fingertips. It is only 1.1 to 2 millimeter, and it is greatest at the back, 50 to 60 millimeter. It also depends on the cortical representation. More is the representation, better will be 2-point discrimination. So larger is the representation in the cortex, better will be 2-point discrimination. It is important for texture determination. So that was about location. So M modality, L location. What about intensity? If someone asks you that you have to increase the intensity, okay, so how can you increase the intensity? See, amplitude is a constant. Even if you increase the amplitude, intensity will not increase. Why? Because it follow all or none law. But frequency, more is the frequency of stimulation, better will be the intensity. Less is the frequency, less will be the intensity. So intensity can be increased by amplitude or frequency. Answer is, it is frequency. Then duration, time between start and end of stimulus. Okay. After that comes sensory receptor. There are 4 receptors. 2 are present in the epidermis, 2 are present in the dermis. How to remember these 2? Very simple. In the epidermis, there are 2. What are those? Number one, we can say it is called as Meissner's capsule. It is called as Meissner's capsule. It is called as Merkel disc. Both are in the epidermis. And doctor, both are for touch also. But what is the difference? Meissner's is for lateral motion. If we are making lateral motion, it will be sensed by Meissner's, and they are maximum in the lips and fingertips. They are the maximum, and they are for lateral motion. They are maximum, and they are in the lips and fingertips. They are for texture. They are for topognosis. Merkel is for which type of touch? It is for edge. It is for corner or pointed object. So both are for touch, but both are different. Now we have one more receptor in the dermis, and that is called as Pacinian capsule. Pacinian capsules. Pacinian, shape of onion. Pacinian, shape of onion. Sense vibration. Which vibration? High frequency. Because sometimes lateral motion is also like a vibration, and they are called as slow frequency vibration. Then the fourth one is your simply Ruffini ending. And this is for mainly stretch or constant pressure. Easy to remember. Ruffini, rough handling. It can be pressure, it can be stretch. Pacinian, onion, vibration, high frequency. Meissner's, low frequency. Merkel, edge, corner, point. And Merkel, because it is for edge and all, it is important for 2-point discrimination. It is also important for Braille technique. Braille technique is used by blind people to read book. So Braille technique is mainly because of Merkel disc. Now, one more thing. Receptors can be either rapid adapting, called as phasic receptor, or slow adapting, called as tonic receptor. So if at the end you have corpuscles, it is very easy to remember. See, at the end you have corpuscles. There are two corpuscles. So these two corpuscles are called as either rapid adapting receptor or simply phasic receptor. On the other hand, all other like Merkel disc, roughly ending, they are called as slow adapting and they are tonic receptor. And they are mainly for vital receptor. So out of four, two are rapid adapting, two are slow adapting. Slow adaptings are also called as tonic receptor. Pain, for pain we don't have receptor. We have naked wire, and those naked wire are called as free nerve ending. Okay. So free nerve ending is a vital receptor, it is a tonic receptor, it is a slow adapting receptor, just like Merkel and Ruffney. Now you can see the diagram because they are asking in the exam the diagram. Meisner's corpuscles in the epidermis, Merkel in the epidermis, Pacinian and Ruffney in the dermis. Please remember this diagram. This was given in one of the examination and they asked what is the answer? Answer was Pacinian corpuscles. So please recognize this also for your exam purpose. Now, if I talk about the afferent, all these four receptors, afferent are same. They all will be taken by A beta receptor. All will be taken by afferent A beta receptor, but for free nerve ending, for pain, afferent is not A beta. For touch, it is A beta. For pain, it is A delta and C fiber. What is the difference between these two? A delta is for first pain, also called as fast pain. Okay, C fiber is for second pain, also called as slow pain. Very simple. A fibers are simply they are myelinated fiber. They are myelinated, and C fibers are unmyelinated. A delta is for fast pain or first pain, and this is called as good pain because it is helping in localizing the pain. C fiber are psychological pain, visceral pain, burning pain. So they are called as bad pain. Bad pain. Neurotransmitter involved in good pain is mainly glutamate. And neurotransmitter involved in C fiber is usually substance P. Substance P. Okay. It is better. It is good pain. And this is bad pain. This is about free nerve ending. Now, algogen. Algo means pain. Gen means generating substance. So, what are the pain generating substance? It can be inflammatory products like histamine, prostaglandin, substance P, serotonin. But they ask you, who is the most potent algogen? Answer will be bradykinin. Bradykinin is most potent algogen. Now, about the analgesic pathway. To understand analgesic pathway, we need to remember what? Spinal cord have interneuron. Spinal cords have interneurons. They have projection neuron releasing enkephalin and endorphin. So enkephalin and endorphin released by projection neuron by spinal interneuron will decrease pain in the sensory cortex. Okay. Now, in the cortex, there are two friends. One is called as periaqueductal gray matter. Other is locus ceruleus. Periaqueductal gray matter releases serotonin and catecholamine. Okay. Serotonin is released from, very important, star question, nucleus raphe magnus. Nucleus raphe magnus. Catecholamines are released by rostral ventromedial medulla. And locus ceruleus releases norepinephrine. Norepinephrine. Now, these all will act on spinal cord to release more and more endorphin and enkephalin, and they will decrease the body pain. It is called as descending pain modulating pathway. Now, Wilczek and Wall theory, gate control theory. See, normally spinal interneurons release endorphin and enkephalin to decrease pain. Suppose due to any C fibers are stimulated because of you are sad, you are not happy, it is a bad pain. So they will inhibit spinal interneuron. They will inhibit whom? Spinal interneuron. So body will pain. That is why when we are not happy, we have body pain. But suppose someone start massaging your hands, or you got body massage, or TENS therapy, trans TENS, transcutaneous electrical nerve stimulation, or acupuncture, acupressure, whatever, or ointment, pain ointment, Okay, these all are type of touch. So they will stimulate A beta, and A beta will stimulate spinal interneuron. And when spinal interneurons are stimulated, they will release endorphins and decrease body pain. So C fibers were increasing our body pain, and because of the tense therapy, massage, ointment. So what is the main point? A beta are dominating because they are myelinated. So the summary will be that myelinated A beta fibers will dominate. And this is important point. Will dominate over C fiber. Myelinated A beta fiber are going to dominate over C fiber. By this, pain will be suppressed. It is called as gate control theory or gate control mechanism. Now comes somatosensory pathway. So receptor we have talked about. Afferent, now they will ascend in the spinal cord. So there are two pathway. One is called as dorsal, other is called as anterolateral. Anterolateral. Anterior is mainly for crude touch. Anterior is mainly for crude touch. Lateral is mainly for pain and temperature. Pain and temperature. In crude touch also comes itch, tickling, and sexual sensation. Rest all except crude touch and pain and temperature. Rest all, whatever you say, fine touch. Okay, fine touch or vibration, proprioception, fine touch, vibration, proprioception, then stereognosis, whatever, no need to remember except pain and temperature and crude touch. Whatever are left, they all are coming from dorsal column. Clear? Dorsal column crosses in the medulla. They will cross in the medulla. Anterolateral column crosses in the spinal cord. So these are the difference which are asked in your exam. Okay. Now simply about the dorsal column. What you will write in dorsal column? Suppose someone touch lower limb. Okay. Someone is touching lower limb, fine touch, you know that. It will stimulate whom? What is this called as, doctor? It is called as fasciculus gracilis. And they will end here in the medulla where? Nucleus gracilis. Very easy to draw also. And remember. And if someone is touching upper limb, it will go via what? Fasciculus cuneatus. It will go via fasciculus. Now it is fasciculus cuneatus. Very easy to remember also. Grass is in the lower limb, so gracilis, and these are cuneatus. Ending in the, now this will be nucleus cuneatus. Okay. On the lateral side, we will have nucleus cuneatus. So fasciculus gracilis, fasciculus cuneatus, ending in the nucleus gracilis, nucleus cuneatus. Now in the medulla, they will crisscross like that, and they will ascend upward. Now they are called as medial lemniscal pathway. Medial lemniscal pathway, and ultimately the relay station is your thalamus, which nucleus? VPL. Don't forget VPL, most important nucleus, ventro-posterior-lateral, and they will go to the cortex. They will go to the third cortex. The first order neuron, second order, and third order neuron. This is your dorsal pathway. Anterolateral pathway is very simple. Suppose pain and temperature or crude touch they are stimulated, they will directly reach where? They will reach in the spinal cord. Okay, and they will cross in the spinal cord anteriorly and laterally, and they will go in the thalamus. Where in the thalamus they will go? Ventro posterior lateral, VPL, and ultimately they will go in the cortex. So first order neuron, second order, and third order. So what difference you can see here? Here it is crossing over happening in the medulla, and here crossing over is happening in the spinal cord. It is called as anterolateral pathway, and the area from where pain pathway is going upward is called as substantia gelatinosa. Substantia gelatinosa. Now, ultimately, everything will reach cortex, and from cortex we will feel everything. pain, touch, temperature, whatever, everything is felt in the cortex, and there is a sensory homunculus. If you look there, the arrangement is vertical. This is your exam question. How is the arrangement? It is vertical. Is it inverted? Yes, it is inverted. Why? Because at the top we have leg, at the bottom we have face. The face is at the bottom, top is the leg, medial is the leg, lateral is the face. So this arrangement of sensory homunculus is vertical and inverted, and representation is based on the usage. Okay, more usage, more will be their area, and maximum representation is present where? In the lips and the thumbs. Minimum area is in the trunk and in the hips. But if we see sensory homunculus, there is no visceral representation, and this is giving the principle of referred pain, because both have same dermatome. So even if there is angina, pain can be referred to the left hand also, because there is no representation of any viscera in the sensory homunculus. Now, Brown-Sequard syndrome. What is this? It is functional hemisection of spinal cord. Here we will get ipsilateral problem in the dorsal tract. Ipsilateral problem with the dorsal tract, because it is hemisection spinal cord, na? And dorsal tract is not crossing. Motor tracts are also not crossing. So ipsilateral problem with the dorsal tract, and ipsilateral also in the motor pathway. But contralateral problem in the anterolateral tract, because we know they were crossing in the spinal cord. So contralateral loss of pain and temperature. So pain and temperature will be lost on contralateral side. Rest all can be lost from ipsilateral side, as well as motor will be lost from ipsilateral side. It is called as Brown-Sequard syndrome. Now coming to the Muller's law. Muller's law is called as law of specific nerve energy. It is called as law of specific nerve energy. Okay, Muller's law. Every nerve is specific. Suppose even Pacinian corpuscles is for vibration. Even if you touch Pacinian corpuscles, it will feel what? Vibration. So every receptor is specific. Every nerve is specific. It is called as Muller's law. What is Weber-Fechner law? Intensity of stimulus which you receive is proportional to the log of stimulus. So whatever you are doing, for example, one child is crying, there is some noise. Okay, 100 or 1,000 children are crying. Do you think noise will be 1,000 times? No, log 1,000. So log 1,000 will be 3 times. 10,000 children are crying, it will be 4 times. So intensity will increase according to the log. It is called as Weber-Fechner law. What is Bell-Megendie law? Dorsal roots are sensory. Very simple. Dorsal roots are sensory. Ventral are motor, you know that. And law of projection, even after amputation of hand or limb, there is some pain because of cortical plasticity. It is called as law of projection. Brain will project that. It is called as phantom limb pain. Pain, and what is the reason? Due to cortical plasticity. So these are the law which they ask in the examination. Now syringomyelia. It is associated with which Arnold Cherry? It is type 1 malformation. Cerebral tonsils will be pushed in the foramen and magnum, then in the spinal cord, and very important, they will lead to dissociative sensory loss. Sometimes they will ask you, what is dissociative sensory loss? Answer is, when there is loss of only pain and temperature, sparing touch and vibration. So touch and vibration, they are not lost. Only when there is loss of pain and temperature, it is called as dissociative sensory loss, or it happened in the syringomyelia, especially Arnold Cherry type 1 malformation. Now this was about the general senses. Now coming to the special senses. So here there were Merkel, Meissner's, Ruffini, Pacinian. Those were the receptor. For vision, who is the receptor? Retina. And who is the relay station? Relay station is again in the thalamus. Which part of the thalamus? Lateral geniculate body. Remember L for light, M for music. Medial geniculate body is for hearing. Lateral is for vision. L for light. Then who is the television? Again, visual cortex. So remember, retina, lateral geniculate body, and visual cortex is the pathway. Now coming to the retina, how many cells are there in the retina? There are 7 cells. Bipolar cell will connect, now this is bipolar cell. This is bipolar cell. It will connect rod and cone with ganglion cell. And rod and cone are connected to each other by, answer is horizontal cell. Now bipolar cells are connected to the ganglion by, then answer is amacrine cell. Now amacrine cells are excitatory or inhibitory. Answer is that they are inhibitory. They causes lateral inhibition. They causes lateral inhibition. How? By releasing which neurotransmitter? Answer is by releasing acetylcholine. By releasing acetylcholine. Now they will ask you, who is the output of retina? Answer is ganglion cell. G cell is ganglion cell. They will form optic nerve. So either they ask you, who is the output of retina? Who is the output of retina? Or who is forming optic nerve? Answer is ganglion cells. The only cell that can produce action potential, again answer is ganglion cell. Okay, so rods are for night vision. They are present in extrafoveal region. Pigment is rhodopsin. On the other hand, cones are for day vision, present mainly in the fovea. Pigment is iodopsin. We know bipolar cell connect rod and cones with ganglion cell. Ganglion cell. Now the only cell in the retina which can produce action potential, ganglion cell. Only output, ganglion cell. Axon of optic nerve, ganglion cell. Horizontal cell connects rod and cone. Amacrine cell connects ganglion cell with bipolar cell, and they cause lateral inhibition by releasing acetylcholine. So I have told you 6 cell. Who is the 7th? The only cell which is supporting, and they have no role in visual processing. They only form blood retina barrier. That cell, doctor, it is called as Muller cell. It's very simple, Muller cell. So first order neuron is rod and cone. Second order is bipolar cell. Third order neuron is ganglion cell. Fourth is in the thalamus, lateral geniculate body. And fifth will be visual cortex. And this will be direction of stimulation, and this will be light. Light will come from ganglion, bipolar, and rod and cone, but direction will be from rod and cone, bipolar, and ganglion. This is how they will be stimulated. How they will be stimulated? Let me discuss. In dark, rods and cones are having which channel? Answer is cyclic GMP dependent sodium channel. So that sodium keeps on coming inside. So during dark, I am telling, mind it, during dark, sodium keep on coming inside. They are called as dark sodium current. And because there is the influx of cation, so they will cause depolarization. And when there is a depolarization, they will open voltage gated calcium channel. Influx of calcium will cause exocytosis of neurotransmitter glutamate. So during dark, glutamate is more or less, it is more. During dark, there is depolarization. It is paradoxical in the retina because when light falls, cisretinol will convert into transretinol when light falls. And transretinol will produce a protein called as transducin. Transretinol will produce a protein called as transducin, which actually is a phosphodiesterase. Cisretinol convert into transretinol. Now, transretinol will produce a phosphodiesterase called as transducin that will convert cyclic GMP into GMP. Now, you know, doctor, the channel is cyclic GMP dependent sodium channel. Now, cyclic GMP is gone. It will convert into GMP. So, this channel will close. Sodium influx will stop, and instead of depolarization, now will be hyperpolarization, and release of glutamate will decrease. This is, everything is paradoxical. Normally when there is excitation, it will cause depolarization. Here when light is falling, it is causing hyperpolarization. Star question. Whenever I say star question, it means it has to come. Now I was telling you about how cisretinol convert into trans. So this is through a cycle called as Welt cycle, and the mnemonic is BALMA, BLMM. Bathmore rhodopsin converts into Lumi rhodopsin, M, meta 1 and meta 2 rhodopsin. So Bathmo, Lumi, Meta 1, Meta 2 rhodopsin. From there, cis-retinol will convert into trans-retinol. Clear? Now, cells in the visual cortex, simple cell will detect feature, complex cell will detect feature, but blobs will detect color vision. Now, color vision pathway in the retina, who is for color? Cones. In the thalamus, which layer is for color? Lateral geniculate body. Okay. Cortex, blobs. And which layer is there in the thalamus? Parvocellular layer. Parvocellular layer. So these all parts are different parts in the pathway which are concerned with the color vision. Cones, parvocellular, and blobs. So in the thalamus, which layer? Parvocellular. There are two, magno and parvo. Magno is for what? Magno is for movement of eyeball. Parvo is for what? Parvo is for color vision. Now cones, there are three cones. L cone is for red. Love is red. Sky is blue. S cone is for blue. Medico's color is green. M cone is green. What is L? Long wavelength. S, short wavelength. M, medium wavelength. If there is problem with the L cone, patient will have protanopia. If there is problem with the S cone, patient can have tritanopia. If problem is with the M cone, he can have deuteranopia. Okay. And if it is decrease problem, then we say anomaly, protanomaly, tritananomaly, deuteranomaly. But if it is absent, it's called as opia. So it can be also called as protanomaly, anomaly. If vision is decreased, not completely absent. Protanopia, protanomaly. Tritanopia, tritananomaly. Absent, opia. Decrease, anomaly. But which is most common color blindness? Red, blue, green, or what? Answer is not blue, but only red, green defect. And this defect is X-linked recessive. Females are only carrier. They will carry it, carrier, and males are affected. That is why males are having color blindness. We were telling about the lateral geniculate body. How many layers are there? 6 layers. Okay. First 2 layers are called as magnocellular. M for magno, M for movement of eyeball. Magnocellular layer are involved in movement of eyeball. Rest 4 layer, third, fourth, fifth, sixth, they are called as parvocellular layer, and they are for color vision processing. They are for processing of the color vision. Now, out of this 6 layer, who are receiving input from ipsilateral side? Who receive from contralateral side? So remember, it's very important. Layer 2, 3, and 5 receive input from ipsilateral eye, and layer 1, 4, 6 will receive input from contralateral eye. Okay. So this is lateral geniculate body, then goes to the cortex. Where in the cortex? Calcarine cortex. And what is the Brodmann area number? It is 17, 18, and 19. It is more myelinated, and because it is heavily myelinated, for the first time it was seen like striations by the Jennery. So sometimes we say they are striations of Jennery, because Jennery was the name of the scientist. Ear, hearing, and balance. Balance is the primary function. Hearing is the secondary function. Balance is the primary function. Okay, hearing is the secondary function. For balance, we have vestibular apparatus. In vestibular apparatus, we have semicircular canal, and we also have otolith organ. Semicircular canal sense angular acceleration. Angular acceleration. Otolith organ can be utriculus, can be sacculus. Both are having otolith, so they are called as otolith organ. They sense linear acceleration. They sense linear acceleration. Out of these two, linear, one is vertical. Utriculus will sense like this if you are driving a car. Sacculus will sense like this. Both are linear, but one as if you are driving a car and your head is going like that, utriculus, and if you are in a lift, sacculus. And if you are moving your head like that, semicircular canal. So balance is the primary function, hearing is the secondary function. For balance, we have vestibular apparatus. For hearing, we have cochlea. In the cochlea, there are scala vestibuli, scala media, and tympani. You can see here, vestibuli and tympani have perilymph. On the other hand, media has endolymph, which is formed by stria vascularis, and they have most of the time potassium. See, scala, these two are having mainly sodium because they have perilymph. So sodium is the dominant cation in the perilymph, but potassium is the dominant cation in the endolymph. And we have organ of Corti in the scala media. They have different types of cell. Largest called as kinocilium, they are stereocilium, and when they are moving towards the tallest, when hair cell move towards the tallest, they cause depolarization. When they move away from tallest, they will cause hyperpolarization. Okay. Now, hair cells can be outer hair cells and inner hair cells. Who is more in number? Outer, but less innervated. Who is less in number but more innervated? Inner hair cells. 95% of innervation is to inner hair cells. Only 5% to outer. But if they ask you who is damaged by giving this drug, streptomycin and all, so answer will be outer hair cells. Okay. So ototoxic drugs are mainly damaging which cell? Outer hair cells. They have deter cells also. They are called as supporting cells. Okay. Now bending towards tallest causes depolarization, away from tallest causes hyperpolarization. We know that. And when they bend towards the tallest, why there will be depolarization? Because potassium will enter, and this entry of potassium will cause depolarization. And what is this called as? Repeat MCQ in your exam. What is that called as? Autoacoustic emission, or simply they are called as Kemp wave. They are called as Kemp wave. Okay. Auditory pathway mnemonic is E. coli MA. E is eighth cranial nerve. C is cochlear nucleus. It can be dorsal nucleus, it can be ventral nucleus. O is superior olivary nucleus. Sometimes they ask the direction of sound, even if eyes are closed, you can tell me that sound is coming from front, back, or who is detecting that? Superior olivary nucleus. Then L is lateral lemniscus. You know medial lemniscal pathway? That is by dorsal tract. It is lateral lemniscus. Then E. coli MA, it is I. Inferior colliculus. Superior and inferior, both. One colliculus is in the visual pathway, other is in the hearing pathway. Eyes are superior, so superior colliculus. Ears are a bit inferior, so inferior colliculus. You can remember like that. M is for medial geniculate body. M for music. So medial geniculate body is in the auditory. Lateral L for light. LGB, that was in the vision pathway. A for auditory cortex. Broadband area is number 41. It is called as what? Hessel's gyrus, temporal gyrus. And for perception, it will go to the Wernicke's area, which is in the superior temporal gyrus. Now, middle ear also has some function. What is that? See, normally the arrangement of malleus incus stapes is such that it has to increase the sound. Normally, okay. But when there is a loud noise coming from outside, this can be dangerous to the internal ears, isn't it? So, stapedius muscle and tensor tympani muscle will contract. And when they contract, they will attenuate the sound. They will decrease the sound. And who is the afferent? Eighth cranial nerve. The sound is coming from eighth. Who is the afferent? Stapedius will be contracted by which nerve? Facial nerve. Efferent is facial nerve. And who is the nucleus? Superior olivary nucleus. Smell, odorant receptor. It is an important point. All odorant receptors are G protein couple receptor. Receptors are on the roof of nasal cavity called as olfactory epithelium. They penetrate cribriform plate. That is why if there is a fracture of cribriform plate, smell is absent. Anosmia. Okay. Now, after ascending upward, they will go to the olfactory bulb. Olfactory bulb have four types of cell, and the mnemonic is MTPG. MTPG. Mitral cell, tufted cell, periglomerular cell, and granular cells. Out of MTPG, MT is excitatory, releasing glutamate. PG, periglomerular cell, and granular cells, they are inhibitory, releases GABA. Then smell will go to the tubercle, piriform cortex, amygdala, entorhinal cortex, but they will relay in the thalamus. Which nucleus? Dorsomedial thalamic nucleus. Then they can go to the orbitofrontal cortex for perception. Now, in the cortex, purpose is what? Discrimination of the smell. This smell is for rose, for jasmine, or whatever. The discrimination of the smell is because of olfactory cortex. Amygdala is for emotion. Entorhinal cortex is concerned with the olfactory memory, and this is degenerated in Alzheimer's disease. You can see here, it is olfactory epithelium. All odorants are G protein couple receptor. They will go in the olfactory bulb, and they have to cross cribriform plate. So by seeing this diagram, you can remember how MTPG all cells are working. Okay. Now, all orderants are G protein couple receptor. So whenever some order will come, okay, alpha will dissociate with GTP and it will convert ATP into cyclic AMP. It will cause influx of calcium and outflux of chloride. This chloride will cause activation of smell. Now, this was about smell. Now coming to the taste. Taste buds are in the circumvallate, folate, fungiform, but not on filiform. This was a question. Nerve supply is ninth cranial nerve, seventh cranial nerve, and these are circumvallate, foliate, and fungiform, not filiform. These are the taste pore in the saliva. These are the epithelial cells. These are called as taste cell, basal cell, and this is gustatory afferent nerve, which will take the taste. Okay. Now we have 5 types of taste: salt, sour, sweet, bitter, and umami. Only salt and sour, they are ENaC. What is ENaC? Epithelial sodium channel, inotropic. Rest all are G protein couple receptor. In the odorant, we were remembering all odorant were G protein couple receptor. But in the taste, only 3 are G protein couple receptor. Sweet is T1. T1 is sweet, the top one. T1 R2, T1 R3. And bitter is T2. You know T2? T2? T2 is bitter, poisonous. And taste, which is umami, depends on metabotropic glutamate receptor R4. It is because of Ajinomoto and all. It is because of L-glutamate. It is called as umami taste. Now, which taste has maximum sensitivity? Answer is bitter. It has lowest threshold. Next question. Out of glucose, sucrose, and saccharine, which is sweetest? Saccharine. It has minimum threshold. Out of glucose and sucrose, you can see here that sucrose is 8 times sweeter than glucose. These are your question. Now coming to spinal cord reflexes. There are 3 types of reflexes. One is called as monosynaptic reflex, other is called as bisynaptic reflex, third is called as polysynaptic reflex. If there is one reflex, monosynaptic, example is stretch reflex. If there are 2 synapses, inverse stretch reflex. If there are multiple synapses, answer will be flexor withdrawal reflex. Flexor withdrawal reflex. Who is the sensor of stretch reflex? Answer is muscle spindle is the sensor. Who is the sensor of inverse stretch reflex? Golgi tendon organ, GTO. What does muscle spindle will sense? It will sense, remember L. L is there. It will sense length, change in the length of muscle fiber. Golgi tendon has a T. It will sense what? Tension. Muscle spindle, if they sense change in the length of muscle fiber, what they will cause? They will cause contraction. And what they will cause? They will cause relaxation. Don't worry, I will discuss. I'm telling that this is the minimum point which you need to remember. What is polysynaptic? Withdrawal reflex. Suppose if you give a noxious stimulus or painful stimulus, on the ipsilateral side, there will be flexion. On the contralateral side, there will be extension. One limb will be off the ground, other will be on the ground. Because if both limbs are off the ground, you will be on the ground. It is flexor withdrawal reflex. Now, coming to the stretch reflex, monosynaptic reflex, this is the main muscle called as extrafusal fiber. This is spinal cord. Okay. Inside every muscle, there is a small chip. Okay. Main muscle is called as extrafusal fiber. It is called as extrafusal fiber. Inside it, there is a chip software called as intrafusal fiber. It is called as intrafusal fiber, also called as muscle spindle. Now, the afferent who are taking the sensation of change in the length of muscle fiber is 1A and 2. Efferent are gamma and alpha. It is called as alpha gamma co-activation. Alpha gamma co-activation. Now, alpha will supply extrafusal fiber to cause muscle contraction. It will cause muscle contraction. And the role of gamma efferent, very important for your exam. Role of gamma efferent is to increase the sensitivity of muscle spindle. And there is one synapse, so it is monosynaptic. The role of gamma is what? To increase the sensitivity of muscle spindle. Role of alpha is to cause muscle contraction. Who is the efferent? 1A and 2. Who is the efferent? Alpha and gamma. Clear? Now, if I take muscle spindle outside and I see it, what I will get? I will get two types of fiber. One is nuclear bag fiber. Other is nuclear chain fiber. One is nuclear bag fiber, other is nuclear chain fiber. Nuclear bag fiber are of two types. They can be dynamic, they can be static. But chain are always static. Bag fiber are like bag of nucleus. Chain are like chain of nucleus. Chains are always static. Now, dynamic and static. Function of spindle is to sense change in the length of muscle fiber. But dynamic will sense velocity of change of length. Because every time you keep on moving, you're not static. Only when you're static, these two will sense tonic length. If length is static, but dynamic nuclear bag will sense velocity of change of length. Clear? Ratio of nuclear bag and chain is always 1:3. If we have 3 nuclear bag in one muscle, there will be 9 nuclear chain. The ratio is 1:3. So ratio is 1:3. Now let me draw a diagram for better understanding. This is your dynamic nuclear bag. This is your static nuclear bag. And this is your nuclear chain. These are the nucleus. You can understand. These are the nuclear chain. Now, we know that afferent of nuclear bag and nuclear chain is 1A and 2. But now I will tell you specifically, 1A is carrying from every nuclear bag and every nuclear chain, either static or dynamic. But 2 will take only from static. This is nuclear bag dynamic. This is nuclear bag static. This is nuclear chain, which is always static. So remember, secondary is always static. S for secondary, S for static. 1 and 2, you know that, but this diagram will tell you exact. 1A is carrying from every nuclear bag and chain, but secondary will take only from nuclear bag static and nuclear chain. Now, gamma was supplying to nuclear bag also and to nuclear chain also, dynamic also and static also. This is called as gamma. Do you remember gamma motor? What was the purpose? Purpose was to increase sensitivity of muscle spindle. Purpose was to increase sensitivity of muscle spindle. Now, they ask you, can you see in the diagram? Gamma is supplying in the center or periphery? Periphery. So, this is the exam question. Gamma supplies to the peripheral. Gamma supplies to the peripheral contractile portion of muscle spindle. Gamma will supply to the peripheral contractile portion of muscle spindle. And gamma is supplying to the dynamic also and static also. Dynamic is called as plate ending and static is called as trail ending. There are two gamma efferent. It can supply to the dynamic as well as static. Dynamic is called as plate ending and static is called as trail ending of gamma. So gamma is supplying to the peripheral contractile or central non-contractile. Center is non-contractile and purpose is to contract the bag and chain so that afferent will be brisk. Clear? Now, if all, one point is very important, all stretch reflex are example of deep tendon reflex. All are, or simply you can say, all deep tendon reflex All deep tendon reflex are example of stretch reflex. All deep tendon reflex, it can be biceps jerk, triceps jerk, knee jerk, all are example of simple stretch reflex. And if they are not coming, why we do like this or clench the teeth? It is called as Gendrasic maneuver. By clenching the teeth, gamma motor neuron discharge will increase. So sensitivity will increase. So 1A and 2 will increase, muscle contraction will increase. So sometimes when reflexes are not coming, we ask the patient to do like that or clench the teeth so that contraction can be brisk. Okay. Now in hypothyroid, BMR is less. In hyperthyroid, BMR is low. That is why in hyperthyroid, we have brisk reflex. In hypothyroid, BMR is less. So we have delayed relaxation phase. See, contraction, delayed relaxation. It is called as hung up reflex. So hung up reflex is characteristic of hypothyroidism. Okay. Now inverse stretch reflex. Who is the sensor? Golgi tendon organ. What does it sense? Tension, force, and passive active contraction. A passive stretch or active contraction. What is the effect? Their muscle was contracting. Here muscle will relax. Okay. Why? It is a protective reflex. Their alpha motor was activated. Here it will be inhibited. Alpha motor will be inhibited by interneuron. So interneuron is there. That is why it is disynaptic. Because now there are two synapses, 1 and 2. So stretch reflex don't have interneuron. It is a monosynaptic. Inverse stretch reflex has an interneuron to inhibit alpha motor. So it is called as bisynaptic or simply disynaptic. Their afferent was 1A and 2. Here from Golgi tendon, afferent is 1B. And here alpha motors are inhibited. It is called as Rensa cell inhibition. What is it called as? Rensa cell inhibition. Now, so corticospinal tract, we will discuss motor pathway. In the motor pathway, the pyramidal tract and extrapyramidal tract. Pyramidal tracts are also called as corticospinal tract. They arise from which layer? Layer 5th of the cortex. And out of all these pyramidal tract, 97%, majority are coming from pyramidal cell. Only 3% are coming from large giant pyramidal cell called as bed cell, cell of beds. Now, when they are coming from cortex, okay, from which area they are coming maximally? From primary motor cortex or pre-supplementary motor cortex or somatosensory? Answer is maximum motor neuron, I mean pyramidal tract, are coming from somatosensory cortex. 30% come from primary cortex, 30% comes from premotor and supplementary motor cortex, 40% coming from somatosensory cortex. Why? Because this is a mixed area. This is a mixed area. All sensory are going into this area and 40% are coming from this area. So for proper sensory motor integration. Now, we know motor neuron can be upper motor and lower motor. When we talk about the motor neuron, cranial nerve and spinal nerve, they are called as lower motor neuron, and upper motor neurons are coming from higher center and controlling lower motor neuron. Now they can either come from cortex or they can come from midbrain, pons, medulla, anywhere except cortex. If they come from cortex, just like we are discussing in the previous slide, they are called as corticospinal tract, or simply clinically we say pyramidal tract. Pyramidal tract. And those who are coming from higher center and controlling lower motor neuron from anywhere except the cortex, midbrain, pons, medulla, whatever, they are called as extrapyramidal tract. They are called as extrapyramidal tract, like reticulospinal, rubrospinal, coming from anywhere except the cortex and controlling lower motor neuron. Basically, pyramidal tract are for skilled motor activity. Basically, and extrapyramidal are mainly for posture, for postural control. Okay, now we can see the pyramidal tract. They are coming from layer 5th of the cortex. Okay, and they are called as corticospinal tract. They will cross internal capsule and they will decussate at the pyramid medulla. And when they are decussating, 80% will cross in the medulla, and those fibers which were crossing in the medulla are called as lateral corticospinal tract, and they are actually for skilled voluntarily activity. So normally we say pyramidal are for skilled voluntarily activity, but these are the actual pyramidal who will cross in the medulla in the pyramid. They are called as lateral corticospinal tract. 20% of the fiber who will not cross, they are called as ventral corticospinal tract. They are like extra pyramidal only and controlling the posture. Controlling the posture. Clear? Now, extra pyramidal can be reticulospinal, rubrospinal, vestibulospinal. Let us discuss except rubrospinal. Okay, rest all will descend medially. It is a law. Normally, extra pyramidal tract they are descending medially, and pyramidal tract descend laterally. But rubrospinal tract coming from red nucleus is actually extra pyramidal, but it descend along with the pyramidal tract laterally. It is extra pyramidal, but it behaves like pyramidal also. It controls distal muscle for voluntary activity. Voluntary activity needs distal control. Posture need proximal control. So rubrospinal tract is exceptionally coming from lateral side, just like pyramidal tract, and controls distal muscle to flex the upper limb. So evolution is new. Rest all, reticulo, vestibulo, tecto, they controls proximal muscle, paraspinal muscle, and anti-gravity muscle for posture control. Okay, you can see here, if they come from vestibular nucleus, it is called as vestibulospinal, reticulospinal, tectum, tectospinal. Okay, and red nucleus is crossing laterally, and it is called as rubrospinal tract. If you see, you will not forget. It is coming laterally. Now, reticulospinal tract can come from RAS, reticular activating system. It is in the pons, it is in the medulla. In the pons, it is excitatory to anti-gravity muscle. So it is working as an extensor. It is working on extensor group of muscle. On the other hand, medullary were inhibitory to anti-gravity. So they were working on flexors. And both are involved in limb movement. So you can walk only because of flexion and extension, isn't it? So both are needed for limb movement. Is this clear, doctor? Now, tectospinal tract. Suppose someone is playing cricket and there is a ball is coming. You will move your neck like that. So movement of neck on the body will be tectospinal tract. Now, if there is decortication, there is decerebration and decortication. If only cortex is lost, it is called as decortication. Corticospinal tract lesion will be there, but rubrospinal tract will be intact. If only cortex is gone, midbrain is involved, midbrain is not involved, upper midbrain damage. It means midbrain intact, pons, medulla intact, only cortex gone. So hands will be on the top. Why? Rubrospinal tract is intact, so hand will be flexed. So extension will be seen only in the lower limb. Why? Because rubrospinal tract is intact, so upper limbs are flexed on the chest. On the other hand, if midbrain is also involved, that is called as decerebration or decerebrate rigidity. That is called as decerebrate rigidity. In this, cortex as well as midbrain both will be involved. Why? Lesion is upper pontine. Lesion is upper pontine. So midbrain gone, cortex gone. So rubrospinal tract is gone. So hand will be not be flexed. Hand will be lying on the side of the body. So you can see rigidity both in the upper limb as well as lower limb. It is called as decerebrate rigidity. Now, difference in the upper and lower motor neuron is that in upper motor neuron lesion, everything is up. Reflexes are exaggerated. Tone is spastic. Babinski sign is positive. In lower, reflexes are hypo, tone is flaccid, Babinski is negative. Now, Babinski positive means what? Flexion of the great toe, fanning of the other toe. Negative means what? Flexion of all the toe, muscle atrophy will be prominent in lower and muscle fasciculation. Now, see this diagram. When we are stroking from the lateral side of the foot, okay, what we will see? In the normal plantar response, toe will go down, flexion. But if Babinski sign is positive due to upper motor neuron lesion or an infant less than 1 year, because of incomplete myelination, Babinski sign will be positive. Toes will be up and fanning of the toes. Is this clear? Now, cerebellum, weight is only 10%, surface area is 25%, has 3-part archie, flocculonodal, It is very, very old. It is for posture and equilibrium. Vestibulocerebral pathway. Paleo, spinocerebral. Function is muscle tone and diadokinesia. What is diadokinesia? Ability to perform alternate rapid movement like this. If there is a lesion, we cannot do like that. It will be called as adiadokinesia or dysdiadokinesia. In the neocerebellum, purpose is planning and programming of the movement, coordination of the movement. So neo, new, paleo, old, arch is very, very old, ancient. Now, vestibulocerebellar is the most important for balance. So let me discuss that. What is, how it happens? Midbrain, pons medulla. Okay, this is your cerebellum. Whatever movement we are making at the level of head, and who will sense? Ears. Primary function of ear is what? Balance. Who? Vestibular apparatus. In the vestibular apparatus, we have semicircular canal, we have otolith organ. Otolith organ are utriculus and sacculus. These will sense what? They will sense linear acceleration or angular? Linear. And these will sense angular acceleration. Whatever. They will be taking from vestibular branch of 8th cranial nerve, take it to the vestibular nucleus and pass it to the third nerve, 6th cranial nerve, as well as 4th cranial nerve, and this is called as medial longitudinal fasciculus. MLF. So this is how it is controlling head orientation. Whenever you make a movement sensed by vestibular apparatus, taken by vestibular branch of 8th cranial nerve, taken to whom? Vestibular nucleus, and they will control your eye movement. I have fixed my eyes on the pencil and doing like this. My eyes are moving. It is called as vestibulo-ocular reflex. It is because of MLF. Okay, and if there is lesion of the MLF, it is causing internuclear ophthalmoplegia. Okay, because it connects sixth with the third cranial nerve, and it coordinates both eye to move in the same horizontal direction. Okay, it is very, very highly myelinated because it is a conjugate important moment. And in multiple sclerosis, when there is a problem with the myelination, we will have internuclear ophthalmoplegia in the patient. And if there is a lesion, maybe unilateral or bilateral, it can be seen, or lesion in the MLF will cause internuclear ophthalmoplegia. It is a conjugate horizontal gaze palsy. We can see here, okay, this is third nerve, this is sixth nerve, and they are connected with MLF. So both eyes are moving. Suppose I am seeing this direction, so this is lateral rectus, this is medial rectus. And if there is a problem, you can see in the main video, I have discussed how nystagmus happen. Okay, it is an important integrated topic for physiology as well as for ophtha. If there is a lesion, it will cause nystagmus, jerky eye movement. Okay, now cerebellum is coordinating all the movement. How? Because it knows every movement in the body. Suppose I am sitting cross-legged, I can forget, but who will remember? My cerebellum. Because there are so many pathways going to the cerebellum and telling about the body. For example, dorsal spinocerebellum, all the proprioception is taken from lower body. Okay, so dorsal will take from lower part of the body. Dorsal spinocerebellum will take all the activity from the lower body. Now you will say ventral is for upper. No, cuneo is for upper, head, neck, and thorax. So whatever movement you are making at the head and all, who will take to cerebellum? Cuneo. Ventral, whatever you want to perform. Suppose I want to pick a glass of water. Even before picking the glass of water, that information will reach to the cerebellum to coordinate the movement. So one copy of anterior motor nerve, motor neuron, will reach to ventral spinocerebellum. Olivo, whatever information are left, all will converge to inferior olivary nucleus, and they will take to the cerebellum by olivocerebellar tract. Tectocerebellum, right now you are seeing me, you are listening me, and you are writing. So eye, ear, and hand coordination. Eye, hand, and ear coordination. Corticopontocerebellar is the longest tract, and this is for coordination of movement. Whatever movement we are coordinating, it is because of this pathway. Now, cross section of cerebellum. How many layers are there in the cerebellum? The layer which has Purkinje cell is called as Purkinje layer, and they are causing inhibition. When I say black, it is inhibition to deep nucleus. And the layer which has granular cell is called as granular layer. It is Purkinje layer. This is granular layer. And granular layer will give you branches at the top. And they are called as parallel fiber. And they look like molecular structure. That is why, doctor, they are called as molecular layer. Clear? Three layers, MPG, molecular, Purkinje, and granular. Now, there are two afferent. One is called as climbing fiber. Climbing fiber will climb from inferior olivary nucleus. First, it will stimulate deep nucleus. Then it will stimulate Purkinje cell to inhibit deep nucleus. This is a loop. It will activate Purkinje to inhibit deep nucleus. On the other hand, rest all afferent are called as mossy fiber. Rest all afferent are called as mossy fiber. Now, mossy will rest in the granular cell, and granular cell will activate multiple Purkinje. This is the problem. Climbing was activating one Purkinje, and mossy will come from various places, rest in the granular, and activate multiple Purkinje. Now, you need to inhibit those extra Purkinje from 3 cell. If they look like a star, we say stellate cell. If they look like a basket, we say basket cell. If they look like a Golgi, we say Golgi cell. But function is same. What? To inhibit these extra Purkinje cell. So this is histology of cerebellum. Now in this diagram, tell me how many layers? 3. Molecular, Purkinje, granular. Okay. How many afferent? 2. Climbing and mossy. Climbing comes from one place, inferior olivary nucleus, goes to one Purkinje. Mossy comes from multiple place, goes to multiple Purkinje. So you need to inhibit all other Purkinje by what? Not granular. It is Golgi, basket, and stellate. Clear? Which is the only cell in the cerebellum that is excitatory? Granular cell. Rest all are inhibitory. Purkinje inhibitory, stellate inhibitory, basket inhibitory, Golgi inhibitory. Clear? So only excitatory cell is granular. Now deep nucleus are 4. Purkinje cells are inhibited in deep nucleus. Dentate, okay, emboliform, dentate, emboliform, and globosus and fastigii. But emboliform and globosus will combine together to form nucleus interpositus. Now, I am going to connect cerebellum with the pyramidal and extrapyramidal now. So, which nucleus of the cerebellum will control pyramidal tract? Dentate, the teeth one. Dentate will control from thalamus to the corticospinal tract. Or you can say pyramidal tract are controlled by which nucleus? Dentate. Now, emboliform and globosus will combine together to form nucleus interpositus, and this will control the most important extrapyramidal. What was that? Rubrospinal tract, the most important one, rubrospinal tract. And doctors, rest all other extrapyramidal, vestibulo, reticulo, tecto, all will be controlled by single nucleus. It is very fast TGI. It is so fast, it can control so many extrapyramidal tract to control your posture. If there is lesion of cerebral tract, what will be the clinical features? Cerebellar ataxia, drunken gait, dysmetria, past pointing, finger nose test will be like that, dysdiadokinesia, intentional tremor, nystagmus, pendular knee jerk, hypotonia, and rebound phenomena. These are the clinical features of cerebellum. Now, basal ganglion is called as basal nucleus. At the resting condition, it is inhibitory, and function is planning of the motor movement. First component of basal ganglion is, what is that? Corpus striatum. First component is corpus striatum, which is made up of CP, canard place. What is that? Caudate nucleus and putamen. Very simple. CP, corpus striatum, made up of CP, canard place. Number 2, lentiform nucleus. Second component is lentiform nucleus. The power of your lens will increase when you prepare for your PG examination. PG, P is putamen, G is globus pallidus. It has two components, globus pallidus externus and internus. Third is a nucleus which is below the thalamus, and the nucleus which is below the thalamus is called as subthalamic nucleus. And fourth, a black substance. Okay, do you know that black substance in the midbrain? Substantia nigra. So these are component of basal ganglion. Now pathway, there are two pathway. Direct pathway is for excitation of thalamus. Indirect is for inhibition of thalamus. And substantia nigra releases dopamine and controls both pathway. What is that called as? Dopaminergic nigrostriatal pathway. It has two parts, compacta and reticularis. But direct pathway will be controlled by D1 receptor, indirect by D2 receptor. And if there is a lesion, it can cause Parkinson disease. We know that. Subthalamic nucleus in the cerebellum, we know the only excitatory nucleus was granular. Here, the only excitatory nucleus is subthalamic. It is the only excitatory nucleus among all the basal ganglion, all. And if there is a lesion of subthalamic nucleus, it can cause balismus or hemibalismus. Balismus word has been taken from belly dance. If you see belly dance, movement is not for the belly. Okay, you are focused on belly, but movement is for the pelvic girdle or pectoral girdle. So it is called as flailing. Balismus is called as flailing movements of the extremity. Flailing movements of the extremity. If it is full, it is balismus, half hemibalismus. So this was about subthalamic nucleus. Now athetosis is mainly due to lesion of globus pallidus. And what is athetosis? It is slow writhing movement. When patient is having slow writhing movement like that, it can be athetosis. But if they are having jerky dancing movement, okay, it is chorea. So slow writhing movement is athetosis, jerky dancing movement is chorea. It can be in Huntington chorea also. It can be in rheumatic fever. It can be Huntington chorea. In rheumatic fever, it is called as Sydenham chorea. In rheumatic fever, it is called as Sydenham chorea. It can be also in case of Wilson disease, copper deposition, hepatolenticular copper deposition. So there are multiple cause of chorea. Now starting with hypothalamus. In the hypothalamus, like thalamus was the relay station of all the conscious activity. Hypothalamus will be for all the subconscious, like food intake, satiety, hunger. So which nucleus is for food intake? Ventromedial nucleus. Which nucleus is for hunger? Lateral hypothalamic. For hunger, who is making you hungry? Lateral hypothalamic nucleus. Who is making you, okay, now I should not take food? Ventromedial nucleus. Clear? So this is about your food intake. Now, food intake can be controlled either by orexins or by anorexins. Orexins will increase the hunger. They are neuropeptide Y. They are agouti gene related peptide. Anorexins will decrease the hunger, and they are CART. What is CART? Cocaine, amphetamine, regulated transcription, and alpha melanocyte stimulatory hormone. They are regulating the satiety by releasing anorexins. So they are called as orexins and anorexins. Now, body temperature. For body temperature, see, we are homeothermic. Our temperature remains constant. So who is behaving like air condition? I mean, when there is a hot climate, we need anterior nucleus. And when there is cold climate, we need posterior hypothalamic nucleus, because this will decrease the temperature by causing what? How we decrease the temperature? By causing sweating and vasodilation. And when there is cold, this nucleus is helping in maintaining the temperature by increasing the temperature by causing vasoconstriction and shivering. So if there is a lesion of anterior hypothalamic nucleus, there will be what? Hyperthermia. If lesion of posterior, it can cause what? Hypothermia. Okay, you cannot maintain the temperature in cold. Hypothermia will be there. Now, physiology of fever. In the hypothalamus, we have set point. We have set point. So if there is some infection, it will increase interleukins, cytokines, so that they will go inside the hypothalamus and they will form prostaglandins. And prostaglandins are thermogenic in nature. Suppose we have 98.6-degree set point and the surrounding suppose become 104. Now your set point will get confused. Now what it will do? It will cause increase in the set point. It will cause increase in the set point. Number 2, how it will increase the temperature? By causing shivering. By shivering, temperature will increase. Okay. And third, it will cause vasoconstriction. So these are the mechanism for fever. That is why there are always a chills and rigor before temperature goes up. But if we take NSAID, prostaglandins will be decreased. And how temperature will come down? By decreasing the set point, number 1. And when you take painkiller or Calpol and all those things, paracetamol, okay, we start sweating. Sweating will decrease temperature and there will be vasodilation. So this is mechanism of antipyrexia. How fever will come down? By taking paracetamol. Now, wakefulness and sleep. Wakefulness, when we are hungry, we are awake. So lateral nucleus, same lateral nucleus. And sleep, remember preoptic nucleus. Preoptic is for sleep and sex. When I say sex, I mean to say sexual hormone, gonadotropin releasing hormone. Then sexual behavior is because of preoptic. And sexual differentiation in fetus is again because of preoptic. Clear? Now, mammillary body needs vitamin B1 and it is important for memory consolidation. So those who are chronic alcoholic, okay, they will not take enough vitamin B1 and there will be degeneration of mammillary body, and those will have Wernicke's, Korsakoff psychosis, and the triad will be confusion, memory loss and ataxia, and they will also have confabulation. What is the treatment? Give injection of thiamine. Now, hypothalamus also regulate endocrine. For example, releasing hormone GnRH, GHRH, CRH. Inhibitory hormones are 2: growth hormone inhibitory hormone and prolactin inhibitory hormone, which is also called as dopamine. Then supraoptic can form ADH, okay, and the osmoreceptors are there. They are present on the anterior nucleus. According to that, only ADH will be released. Then paraventricular nucleus can release oxytocin. Now, dorsal nucleus and lateral nucleus, they are for aggression, they are for anger, and this excessive anger is prevented by whom? Cortex. So if there is decortication, cortex removed, we will have excessive anger, and that is called as sham rage. Normally anger is rage, anger, jealousy by dorsomedial and lateral nucleus. But if cortex is removed, it will become sham rage. In animal, we will see hissing. It can be eliminated by ablation of hypothalamus. If you want to treat, you can ablate hypothalamus. Suprachiasmatic nucleus is called as biological clock. It is maintaining the circadian rhythm. See, these are your beautiful eyes. When light are going in the optic chiasma, above the optic chiasma, we have this clock. It is for biological clock, circadian balance. And it also influences pineal gland to release melatonin in dark. Melatonin in darkness hormone. So, suprachiasmatic nucleus and melatonin, they are maintaining the circadian pattern. So, they are called as biological clock. Reward center is in medial forebrain bundle, and nucleus accumbens is involved for, addiction because dopamine is involved. Sexual behavior preoptic we have discussed already. Now, what is the effect caused by stimulation of certain part of hypothalamus? Because when scientists were working, they tried to stimulate different part and they got different responses. Sometimes in the exam they ask you that you should know that if you stimulate posterior and lateral hypothalamus, BP and heart rate will increase. Insomnia will be there. Insomnia is due to this, and somnolence result from lesion of caudal hypothalamus. Preoptic, opposite area. Posterior and lateral, if you stimulate, BP high, heart rate high. Pre-optic, if you stimulate opposite, BP will be less, heart rate will be less. If you are going to stimulate mammillary body, lips start moving, licking the lips, swallowing, feeding reflex. If we stimulate lateral hypothalamus, thirst and eating, but also increase general level of activity of so when we are hungry, we are active now. Sometimes it can cause overt rage and fighting. Okay. Limbic system, limbic word is from circle. It is a ring. Like anterior cingulate is involved, posterior cingulate, mammillary body, hippocampus, amygdala, parahippocampal. These all are part of limbic cortex. They are for cognition, attention, and emotion. Amygdala is called as window of limbic cortex. Okay, and lesion of amygdala will cause Kluver-Bucy syndrome. Lesion will cause Kluver-Bucy syndrome, where there can be hyperorality, hyper tendency to put everything to the mouth, hypersexuality, libido will increase, hyperorality, hypersexuality, fear will be lost, no fear. So it was done in some monkeys. Actually, it is in the temporal lobe. So when there is a bilateral destruction of temporal or specific lesion of amygdala, they developed Kluver-Bucy syndrome. Now, Papez circuit is involved. Mnemonic is HMT CPE. Hippocampus, mammillary body, thalamus, CPE. Cingulate gyrus, parahippocampal gyrus, and entorhinal cortex. Now, this T is thalamus. Sometimes they ask you which nucleus of thalamus? Anterior nucleus of thalamus. It is called as Papez circuit. Now, EEG can be remembered by simple mnemonic gamma, bat, dance. So, gamma greater than beta, greater than alpha, greater than theta, greater than delta. Now, gamma, suppose it is a quick revision, you want to revise everything very fast in a lesser time. Now, you don't have time enough. So, gamma, focused. Now, you have focused attention. So, which wave will be there in your brain? Because you are revising very fast. Focused attention. Which wave? Gamma wave. Frequency will be highest, 30 to 60 hertz, or sometime 80 hertz, 40 hertz. Okay. So, gamma, focused attention. But after certain time, suppose your attention is there, you are attentive, your eyes are also open, okay, but not that focused like gamma. Which way will be there? Beta. And when you read beta, it becomes 13. So 13 to 30 hertz. Very simple. After that, suppose you close your eyes. Okay, now I will listen to sir. Okay. So when you close your eyes and you will become inattentive, relax, frequency will be 8 to 13 hertz. You have played your video, I am just speaking and you are sleeping. Just close your eyes now. But suddenly, who knows, you go and get into theta, where NREM stage 1, wave frequency will be 4 to 7 hertz. Okay, NREM stage 1, I am speaking and you are sleeping, NREM stage 1. And after certain times, I am speaking and you are sleeping. Delta is for deep sleep. Deep sleep. NREM stage 3 and 4. And frequency is even less than 4 hertz. So within 20 minutes, you went from focused attention to deep sleep. I hope now you will not forget. Now, sleep is divided into two categories, non-rapid eye and rapid eye. There are 4 to 5 cycles, each of 90 to 110 minutes. NREM is usually 60 to 70, REM is usually 15 to 20. Whenever we start sleeping, it always starts from NREM, goes to REM, then NREM, then REM. But as sleep continues, okay, NREM will keep on decreasing, REM will keep on increasing. So when we wake up in the morning, late, most of the sleep will be REM. No use. And during narcolepsy, when you are sleeping in daytime, excessive sleep, because of problem with the orexins, orexins make you awake. And if there is a mutation of orexin, we will be sleeping in the day. So during narcolepsy, it starts directly from REM, not NREM. Now, NREM is a deep sleep, actual sleep, quiet sleep, orthodox sleep. There are 4 stages. In one stage, we have alpha and theta. In second stage, we have K complex like that and sleep spindle like that. They are characteristic. And this is the longest phase. Okay. 3 and 4 are having only, delta wave. It is not gamma, it is delta wave. Gamma waves are the focused wave. In stage 3, delta wave start appearing, but in stage 4, more than 50% are delta. Deep sleep. What will the changes in NREM? You are relaxed. BP will be low, body movement will be low, temperature will be low, heart rate will be low. But respiratory rate is going to be low in both REM and NREM. Why? Because when we are sleeping, it will suppress what? Respiratory center. So either we are in REM or we are in NREM, respiratory rate is always low. REM sleep are rapid eye movement. Brain is active, but body is like paralyzed. Why? Because we see alpha beta wave. Muscle will be atonic except extraocular muscle and diaphragm. The first muscle to get into atonia is neck muscle, and because it is a paradoxal sleep, so BP will increase, heart rate will increase. In males, there can be penile erection, and in females, there will be sexual arousal. In both, it is paradoxal sleep. You can see ocular movement are only in REM or you are awake. Muscles are atonic in REM, and EEG you can see when we are awake, we have alpha wave, beta wave. In stage 1, we have mainly alpha wave and then theta wave. Stage 2, K complex, sleep spindle. Stage 3 and 4, you can see amplitude is high, frequency is less, so delta wave. Delta wave is for deep sleep. Dreams can be both REM and NREM. In REM, dreams are longer, visual, emotional, not connected, fictional. But in NREM, dreams are short, dreams are less emotional, dreams are conceptual and related to the reality. Now, learning and memory. There are two parts of brain. L for left, dominant, and L is logical brain. It is dominant in most of the right-handed person. R for right, non-dominant. R for representational. So left is concerned with the logic, language, speech, memory, math. Right is concerned with the intuition, art, music, dance, spatial memory. And if there is a lesion of right side, there is hemispatial neglect and stereognosis. What is hemispatial neglect? Person will not take care of half of the body, as if only half is existing. He will shave on the half side, he will comb on the half side, he will dress on the half side. It's called as hemispatial neglect. Lesion on the left will cause aphasia, aphasias. Now, memory can be of two types, either declarative or non-declarative. Declarative are also called as explicit memory. You can declare what is your name, okay, fact. Semantic memory. If event, episodic, how was your first day in MBBS? Episodic memory. So they are declarative, and the location is lateral and anterior temporal cortex, prefrontal cortex. For the event, we have hippocampus and medial temporal lobe. That was lateral and anterior. Episodes are more close to the heart, medial. Non-declarative are implicit memory. If I ask you, can you do lap chole surgery? You can say, yes, I can show you. Can you drive a car? Yes, I can show you. So it is non-declarative, skill-based. Number 1, procedural. If you have learned some skill, it is procedural memory. And which part of the brain is involved? Corpus striatum, basal ganglion, cerebellum, motor cortex. Priming and perceptual. If I say, I am going to write a name of a country, tell me which country is this. Okay, and you will say Pakistan. If I say, I am going to write name of a city, tell me. Immediately you can say Lucknow. So your brain is evolved, primed. I am priming and you are telling me. There was a question in the exam, who discovered EEG? And student was not able to answer. Then examiner said, it has something to do with MACD. Then a student said, Hans Burger. MACD, burgers are famous. So examiner has primed. So this is called as priming and perceptual, and center is neocortex. Associative learn. When we associate and learn, like Pavlov dog experiment, like operant conditioning, it is called as associative learning. Classical conditioning, operant conditioning, and center is amygdala and cerebellum. Non-associative. When you repeat the same thing again and again, sometimes you become more sensitive. It is called as sensitization. And sometimes you become habituated. You will decrease your response. That is called as habituation, reflex pathway. Now, for speech, we have Broca's area. Broca's area is the motor area for word formation and located in the inferior frontal cortex. If we have Broca's aphasia, okay, word formation will be lost. Fluency is lost. It is called as non-fluent aphasia. Understanding is there, comprehension is there. We will follow the command, but we cannot speak correctly because of less word formation. We will understand everything, but in speaking, word formation will be poor. Repetition is lost. In Wernicke's area is Brodmann area number 22. Broca's was Brodmann area number 44. In Wernicke's area, it is a sensory area for understanding, for comprehension. That was in the inferior frontal. This is in the superior temporal. It is superior to the inferior. See, that was only forming the word. But this is understanding what I am saying. This is for comprehension. So if there is Wernicke's aphasia, fluency is not lost, understanding is lost. So it is called as sensory aphasia, fluent aphasia, comprehension lost, neologism will be there, repetition lost. And if Broca's area and Wernicke's area are connected by arcuate fiber, if there is a lesion of arcuate fiber, word formation good, fluency good, understanding good, only repetition is lost. It is called as conduction aphasia. In case of anomic aphasia, there is problem only in the written language. If I write, you will understand. If I speak, you will understand. But if I write, you cannot. Because lesion is in the angular gyrus. From visual understanding, it goes to the Wernicke's area through angular gyrus. If lesion is in the angular gyrus, we cannot understand the visual cues. The problem will be in the written language. Now, what is circumvallate organ? That organ that does not obeys blood-brain barrier. It is called as circumvallate organ. And the mnemonic is M-SOAP. Medial eminence of hypothalamus, subphonical area, OVLT, organum vasculatum of lamina terminalis, area postrema and posterior pituitary. These organs are not obeying blood-brain barrier and they are called as circumvallate organ in the brain. Now, so just revision point of view, we have discussed thalamus, nucleus, everything. VPL, ventro-posterolateral nucleus, where we have discussed in the both tract, spinothalamic and dorsal tract. Every tract is passing through the same nucleus, VPL. So all the sensation will be carried by that. And their destination will be primary somatosensory cortex in the parietal lobe, ventral, postero, just remove lateral and put medial. That was VPL. Remove lateral, put medial. It is VPL, it is VM. It is VM. VPM. That is VPL. Remove L, put M. Remember the mnemonic. Very pretty makeup goes on face. Of course, makeup will be on the face now. M for makeup. So it will carry sensation from the face as well as taste. Trigeminal and gustatory pathway. Destination is same. Now lateral geniculate body. L for light. So it is for vision. Optic chiasma, optic nerve. You know the pathway. Medial geniculate body. M for music. Going there only. Hearing. Again same. E. coli MA. Superior oli, inferior colliculus. Now, this is important. Ventral anterior and ventral lateral. Which nucleus of the thalamus is involved in basal ganglion? Motor. These are the only nucleus of the basal ganglion and cerebellum involved in cerebellum and basal ganglion that are motor. Okay. So this is all about neurophysiology. Thank you.